It strikes me that in amongst the huge budget the NHS has, this isn't enormous, but it could make an important difference, couldn't it, if they could clamp down on it?
Yes, I mean, we spend about £675 million looking after Brits who have treatment abroad. We're only recouping a very small proportion of that here from people who don't reside in the UK. And I think this plan to recoup the money that we spend on people who aren't eligible for NHS treatment is very timely. I think most people are in agreement with it. The problem is how it's implemented. Now, some people will say it's too much of an administrative burden. I don't buy that at all. After all, somebody who's on not much more than a minimum wage, sitting down as a receptionist in a GP's surgery or in the hospital, in a hospital setting, recouping £3,000 or £4,000 for a non-urgent operation like a hip operation is more than going to pay their way very quickly. So that's perfectly doable. I think the problem is, when does emergency care become emergency care and when is it non-urgent? So it's easy to charge people for, say, a hip operation or a cataract that is a non-urgent procedure. Much more difficult when it's an immediately necessary treatment or an emergency treatment.
What actually is changing? Is it the sense that it will be a legal duty, or is it the types of cases that hospitals are going to be charging for?
No, it's the legal duty to charge patients who are non-resident in this country for non-urgent procedures.
It's not been a legal duty up until this point. It's just been a sort of requirement, but not enforced by law. Is that what's being
There's never been
up?
a mechanism whereby NHS hospitals can charge people who are not eligible for treatment, and we may think that is absolutely crazy, and it has been for many years. But there's no question that it is a system that's being abused, and we have 1 in 14 people who are on a waiting list for a procedure people who are eligible for treatment. Something like 3.7 million just waiting for hips and knees at the moment, and a third of a million of those waiting more than 18 weeks for those procedures. So another question is whether we should treat any overseas patients in NHS hospitals when we're full to capacity already. Those people could be seen in private hospitals if they had private medical insurance, as we're encouraged to do when we go abroad to places like America and Australia.
So will the difficulty be the practical implementation of this, Hilary, getting the money from these people?
Yeah. It'll be very difficult because who will do that? There's no current mechanism to do that. Secondly, how will they determine when is a case an emergency and when is it non-urgent? For example, if somebody comes into hospital with chest pain, it only becomes an emergency if you've ruled out something more trivial like a muscle pain, and vice versa. You can only often say it's an emergency in retrospect. So does that mean that everybody coming into accident emergency is classed as an emergency? Probably does. So it will be difficult, but I think the principle is very important and something we do have to enforce to save as part of saving the NHS.
And the cost could be up to £500 million a year in savings.
Which would be very considerable.